This narration will cover diseases of the endocrine system. We're going to start at the top and work our way down as we go through these. So first up, remember that when we have endocrine disorders, we have, because the endocrine glands, because they're all glands, they secrete hormones. And when you have a dysfunction of an endocrine gland because of a failure of a hormone, then a lot of times our treatments are just to replace that hormone. And so when we later talk about the pharmacology, you'll notice that if we have an underactive gland where we have depressed hormone levels, we replace that hormone. If we have an overactive gland, then we have elevated hormone levels, and we have to suppress the gland somehow. So a lot of times what happens is that the gland itself is malfunctioning, but sometimes it's feedback systems. As an example, we all know that the pituitary gland secretes a lot of different hormones that stimulate other glands. And if the pituitary gland isn't working correctly, then those other glands aren't going to work correctly either. And so the problem can be either primary in the gland itself or secondary in, say, the pituitary gland because it's stimulating it. The other thing that can happen is that our cells might just not really function as well. So let's say a hormone is trying to do its job with some cell, but that cell just is resistant to that hormone. That's what happens in type 2 diabetes. So it's not really a failure of the gland in that case, of the pancreas, like it is in type 1, but rather a failure of the target cells. And so when we do have target cell failure, we either have a decrease in the number of cell receptors, or maybe those receptors just don't function as well. Sometimes we have the destruction of receptors from antibodies, or sometimes we have antibodies that are mimicking the hormones, but they're binding to the receptors, but they're not actually doing what the hormone is supposed to do. And so all of those things can cause an endocrine problem. Now, one of the things about the endocrine system is that often our disorders that are associated with it are discovered when a patient comes in for another reason. And so let's say that the patient comes in with a very high heart rate or a very low heart rate. We're going to be looking at their thyroid gland because that's responsible for metabolism and it affects your heart rate a lot. So a lot of these endocrine disorders don't get diagnosed right when they come around. All right, so first up, we're going to talk about the pituitary gland. And remember that the pituitary gland has the anterior lobe and the posterior lobe. And you can actually have failure of one or both lobes. So remember that the anterior lobe secretes growth hormone, TSH, ACTH, prolactin, and then our gonadotropic hormones, FSH and LH. Remember that your growth hormone is secreted continuously as a child and into puberty because we grow, right? But it is not supposed to keep being secreted in such high levels as we hit adulthood. TSH, our thyroid stimulating hormone, stimulates the thyroid gland to secrete T3 and T4. ACTH stimulates the adrenal cortex to release cortisol. Prolactin stimulates the mammary glands, and our gonadotropic hormones stimulate the testes and the ovaries. In the posterior lobe, you have antidiuretic hormone, which is also known as vasopressin, which causes you to not diurese. So your kidneys retain fluid. Vasopressin is also a very potent vasoconstrictor. And so it will, or ADH is a potent vasoconstrictor, and so it raises your blood pressure. And then finally, oxytocin, which stimulates the uterus. All right, so let's talk about our pituitary disorders. First up, we have SIADH, or Syndrome of Inappropriate Antidiuretic Hormone. And in this one, it's inappropriate and it's increased, okay? And so that's how you can remember that it's increased, is the I, even though it doesn't actually stand for increased. But in here, we have hypersecretion of ADH. And when we see our patients with SIADH, because they are secreting so much antidiuretic hormone, the amount that they are urinating is just tiny. And that urine is so concentrated. It's usually a really dark yellow or even a brown. So a dark amber / brown color, maybe a tea colored. And it's really concentrated. And when urine is concentrated, that means it's got a lot of sodium in it, and it's got a really high specific gravity. Remember, specific gravity is how we measure weight of urine. Okay, so 1 is the weight of water, and urine, because it's got stuff in it, is always above 1. But this urine is super heavy. And then the concentration of it, or what we call urine osmo, is really high. And that just is because it's super concentrated. Now, ADH, because you're retaining all this water, it's different from the old standard, which was that if you lose salt, you lose water. And then if you retain salt, you retain water. In this case, it's not really the whole water follows salt thing. Instead, your kidneys are retaining a ton of fluid, but not the associated sodium. And so you're diluting the sodium level in your body, and your sodium level then, your serum sodium level goes way down. So you have hyponatremia. And then your patient has manifestations related to that. So because they're retaining all that water, they have a huge amount of edema. Their blood is very dilute, which is the hyponatremia. And then the osmolality of the blood now, because it's so dilute, is very low, or hypoosmolality. So it's exactly the opposite of the urine, right? The urine's super concentrated, the blood is super dilute. So what causes these, typically when we have SIADH, a lot of times it is going to be damage to the brain. Okay, so maybe a head trauma. More than likely, though, if somebody comes in presenting with SIADH, a lot of times it's a tumor. So it's a cancerous tumor that is secreting ADH. So when somebody comes in with that and they don't have a head injury, we're going to look for cancer. So how do we treat SIADH? Well, we give them diuretics. And so because we got to get that fluid off. The other thing that we do is put them on a major fluid restriction. And when I say major, I mean major. This fluid restriction is going to be sometimes 300 to 500 mLs a day. And so that's, just a little over 1 cup, one actual measuring cup. But they're not thirsty because their sodium level's so low. So that's helpful. And then the other thing is, ideally, we find the cause and we treat the cause. So if it's cancer, we treat the cancer and hopefully improve the SIADH. If it's a head injury, we treat that. All right. On the other end of the spectrum, exactly the opposite of SIADH is diabetes insipidus, okay? So DI, or diabetes insipidus, in this case, it's not that we have too much ADH, it's that we don't have any. So all these patients do is pee. So they have a massive amount of polyuria, and their urine is super dilute. It looks like really pale lemonade. So and they pee a lot, okay? So polyuria. They're creating a lot of really dilute urine. And so that urine has hardly any sodium in it, has hardly any, solutes in it. And so the urine osmo is really low, okay? And then the urine sodium level is also really low because it's so dilute. But in the body, because we are losing all that water, the body sodium level, the serum sodium, is really, really high. So you have hypernatremia. And then because that sodium level is so high, you also have this hyperosmolality, because remember that osmolality is your concentration, and mostly that's due to sodium, because our serum levels of sodium are so much higher than of anything else. Now this can either be a neurogenic diabetes insipidus, and this happens with head trauma or brain surgery, and it's really, really common when you've had brain surgery, especially on your pituitary gland, because it kind of shocks the pituitary gland, and so all of a sudden it's not secreting any ADH, and that's neurogenic. Now, a rare kind of DI is nephrogenic, which is when your pituitary gland is working okay, your kidneys just aren't responding to the ADH. Psychogenic is a little bit different, and it has to do with the need to, a psychological need to eat a lot of salt, and then it causes you to drink a lot of water and then therefore have a lot of urination. So the ones you need to really know are neurogenic and nephrogenic. And the neurogenic one is the most common. So how do we treat DI? Well, remember how I said the other name for ADH is vasopressin, and we have synthetic vasopressin. We also have a medication called desmopressin. Both of them mimic the action of antidiuretic hormone. It comes as a nasal spray, it comes as tablets, it comes as an injection. And what they do when we inject vasopressin IV, what happens is that the kidneys start to resorb all that water. So all of a sudden now we've got some antidiuretic hormone. Now this isn't going to work for the nephrogenic. But for the neurogenic DI, this is how we do it. Now we also have to give them a lot of fluids because they are so dehydrated. And so we have to give them fluids. And so we encourage them to drink. We probably have them on IV fluids, but then we're also going to give them this. It does concentrate the urine and it reduces the excretion. Now, if this happened after a brain surgery or a head trauma, a lot of times it's temporary. The pituitary gland is just kind of shocked and it'll come back, and then it'll start secreting the ADH again. The other things that we use this for, though, when we use desmopressin, which comes in that nasal spray, like I was saying, so it is antidiuretic hormone, and as a nasal spray or as a tablet, we give this to kids who wet the bed, because then they stop producing urine overnight until it wears off, and in the morning they're fine. And so, which, by the way, bedwetting until age like 10 or so is actually pretty common and normal, because kids sleep so deeply that they just don't wake up when they have the need to urinate. So the other thing that these are used for, because vasopressin is also a potent vasoconstrictor, if somebody has severe hypotension, such as in the event of a code situation, we can give IV vasopressin, and that will increase their blood pressure. It also will vasoconstrict esophageal varices. Remember, those are the engorged veins in your esophagus that come when you have liver failure and portal hypertension. Well, the use of vasopressin constricts those, and then they're less likely to rupture. All right, so when we have pituitary problems, like I said, we often have we often have a problem with the entire pituitary. So let's say the anterior pituitary, okay, or the posterior. but it's usually the anterior one that doesn't work right. And so when the pituitary gland isn't working right, that can actually, that's what we call hypopituitarism. Now, sometimes the pituitary gland just has an over or under secretion of one hormone, but in panhypopituitarism, it has a deficiency of all of the anterior pituitary hormones, okay? So it's not going to secrete growth hormone or ACTH or TSH or your gonadotropins. It's not going to produce any of them, which means that all of those glands that they stimulate are not going to produce their hormones either. So how can this happen? There's a couple of different ways. If the patient is hemorrhaging and the blood pressure gets really, really low, or the patient's in shock and the blood pressure gets really, really low, both of those can, with the lack of blood flow to the brain and the lack of blood flow to the pituitary gland, can actually then cause the pituitary gland to infarct or die, just like a myocardial infarction. Sheehan syndrome is a specific loss of blood during childbirth. So either they hemorrhaged during childbirth or they had just a really, really, really low blood pressure for another reason. We call that Sheehan syndrome. It's the same though, it's particular to childbirth. Now, if we do have a problem with the pituitary gland and it's not secreting its drugs, or maybe its hormones, or maybe we're trying to figure out what's going on with it, then we can use a couple of medications here. So first up, cosentropin is synthetic ACTH, and it stimulates the release of cortisol from the adrenal cortex. And so here, we will be able, if say your patient's adrenal cortex isn't secreting cortisol, well, we got to figure out if it's the adrenal gland or if it's the pituitary gland. And so what we'll do is actually called a cortisol stimulation test, where we inject this medication, cosentropin, which is that synthetic ACTH, and we see if the adrenal glands respond. Do they secrete the cortisol that they're supposed to? If they do, then we know they work just fine and it's a pituitary issue. But if they don't, then we know, well, the pituitary is okay. The adrenal glands just aren't functioning anymore. And so we have to supplement it. Now, the other thing that we use cosentropin for is to actually treat wasting that is associated with HIV infection. And that is because some of the wasting is due to insufficient adrenal gland function. And so we give them cosentropin, which is that ACTH, to stimulate their adrenal glands to work a little bit better. Now, some side effects of that is it does promote the kidneys to retain sodium, which means sometimes they're going to get some edema and also some hypertension. So this isn't a drug to be given lightly, although we do use the cortisol stim test pretty often. We do that pretty often. All right, somatropin and somatrem, these are synthetic growth hormones, okay? Recombinant means we've made it with DNA technology. And this we'd use to treat patients with deficient growth hormone. Now, there's a couple different kinds of dwarfism. The first one is the achondroplasia genetic mutation. That's a genetic mutation, and injecting those patients with growth hormone isn't going to do anything, okay? However, if they have a deficiency in growth hormone because their pituitary gland isn't secreting it, then that will be fixed with the injection of this. And so somatropin, when we give these growth hormone injections, will allow the child to grow and also to hit puberty. If you're so we inject growth hormone, we also inject some of the other pituitary hormones in these kids who don't have a functioning pituitary gland. Without it, they won't grow and they won't hit puberty. Okay. So I actually have an example of that would be a child who's diagnosed with brain cancer. And a lot of times that brain surgery, it affects the pituitary gland. And so remember, I talked about that, right? How brain surgery kind of shocks the pituitary gland. Well, if that pituitary gland doesn't recover, then you've got an issue because now that pituitary gland isn't secreting the hormones that it needs to. So when growth hormone is prescribed, one of the things is that it's not immediate, right? You don't give the injections and expect the child to have a growth spurt overnight. So you keep a journal and you reflect the child's growth. So you're looking at height and weight for something like that. All right, hyperpituitarism. This is where your pituitary gland is overactive. And a lot of times this is caused by a pituitary tumor. Now, these pituitary tumors are usually benign, but your patient may complain of a headache and tiredness. They may also have visual changes because regardless of whether it's benign or not, it's still a tumor in your brain. And so what happens is that your pituitary gland then starts to secrete some extra hormones. And it's usually not all of them, but because it's working so hard to secrete one of them or maybe two of them, then you have hypopituitarism of the ones next to it. Okay. And so, a lot of times with this hyperpituitarism, then we'll have the excess secretion of, say, TSH, but then not so much secretion of, say, ACTH, because the gland is so busy producing the other hormone. So here's an example of hyperpituitarism, and this one is actually the hypersecretion of growth hormone. So specifically, when growth hormone is hypersecreted during childhood and adolescence, then we get a syndrome called gigantism. Because those kids are still growing, okay? The long bones haven't fused, and so their bones will still grow. Their legs will be longer, their arms will be longer. This is gigantism, okay? However, after puberty, when you have the hypersecretion of growth hormone, the bones can't grow, okay? And so your long bones can't grow. But what can grow is your chin, your forehead, your nose, your hands, your feet. All of that is due to hypersecretion of growth hormone during adulthood. Unfortunately, once we fix it, it doesn't go back to its regular size, okay? However, it'll stop growing. How do we fix it? We remove that tumor. All right, one of the other medications that does affect the pituitary gland is Octreotide. And Octreotide is a medication that is used to counteract tumors that secrete vasoactive intestinal polypeptide, or VIP. Now, what VIP does is it causes a lot of profuse watery diarrhea. Octreotide actually reduces it for somebody who is having this crisis. Now, one of the off-label uses for Octreotide is actually for GI bleeds, and that's because it decreases portal hypertension, okay? So now this doesn't really make sense, right? So Octreotide, it brings the blood pressure up when we're treating the VIP syndrome or the carcinoid syndrome, but it brings the liver blood pressure down. That's because what it does is it vasoconstricts. And so within the portal venous system, okay, your portal system in your liver, those veins with portal hypertension, all of those vessels are just engorged. They're huge, right? But if we vasoconstrict, they tighten up. And while it may, and then the blood doesn't collect there anymore. So it's a little bit different than the rest of your body, okay? And so if we can reduce that engorgement, then bleeding esophageal varices will also start to come down and become less engorged and therefore less likely to bleed. But in the body, in the rest of the body, that vasoconstriction results in an increase of blood pressure because we're vasoconstricting all of the blood vessels at the periphery to bring all the blood to the middle to increase the blood pressure when we have a severe hypotension. All right. If there is hypersecretion of prolactin, so remember that's another one of our pituitary hormones. So when we have a tumor, it's called a prolactinoma that actually is secreting just extra prolactin. And this can cause issues with the menstrual cycle. It can also cause the bones to become brittle. That's osteopenia. In men, it can cause hypogonadism, impaired libido, and a decrease in sperm count. All right, that's going to be the end of this narration, and the next one we'll pick up with the thyroid gland.